Hi. As you can see, I'm trying some new things this time. New background, um, maybe a couple other things. Give me feedback. Let me know whether this setup is more to your liking or less. So lately I've been doing a playlist, a series of videos about myths regarding psychotherapy. But there are myths about medications too, and I'd like to do one today on what might be the most fundamental myth about psychiatric medications, the idea of a chemical imbalance. Now, in addition to a psychotherapist, I'm a physician, I'm an MD, and I do prescribe psychiatric medications. But as we'll talk about today, there is no such thing as a chemical imbalance in psychiatry. In fact, whenever a cause of a psychiatric condition is discovered, it leaves psychiatry and goes to another specialty of medicine. We'll talk about that more later. But you might ask, how can I prescribe psychiatric medicines when I know there's no chemical imbalance that I'm correcting? And that's what we'll talk about today. I'm Dr. Stephen Reidbord, and this is More Than Meds, where I talk about psychotherapy and psychologically informed psychiatry. This idea of a chemical imbalance to explain psychiatric conditions comes from an old theory. It's called the theory of biogenic amines. And although that's a mouthful, the concept is pretty simple. When psychiatrists years and years ago evaluated depressed patients, they seemed to have low energy, lack of motivation. They seemed to be lacking something in their brains that was excitatory or stimulating, something that the rest of us who aren't depressed have. And so they hypothesized that the medicines that were given for depression would correct this chemical imbalance in the brain by adding more excitatory or stimulating chemicals in the brain. And as a matter of fact, the antidepressants that were used then, and actually the ones we still use now, either stimulate the release or increase the presence of stimulating neurotransmitters, brain chemicals, or are analogs. They look like those brain chemicals. And so it's a very compelling theory that we are supplying the brains of these depressed people with chemicals that they are lacking. We're giving them back some of those factors that cause people to have energy and excitement and happiness that they were naturally lacking. There's only one problem with this theory, and that is that there's no evidence that it's true. It's a simple, compelling idea, and so it's been promoted.
While the cause is unknown, depression may be related to an imbalance of natural chemicals between nerve cells in the brain. Prescription Zoloft works to correct this imbalance.
Unfortunately, this kind of simple notion of how this works is also why an unfortunate number of my colleagues, psychiatrists and other physicians who prescribe antidepressants, sometimes describe chemical imbalances as the rationale, as the reason to take an antidepressant medication. I think most of them kind of know that that's not really true, but that it's a good story. It hangs together, it's simple, patients understand it, and therefore it's a good argument for taking an antidepressant medication, even though, as I say, there's been no evidence that chemical imbalance actually is the cause of depression. In fact, there was a study published last year, it got a lot of press, in which the authors really made a very compelling case that there is no scientific evidence that a lack of serotonin causes depression. This is a common example of the chemical imbalance idea, that people who are depressed have low serotonin, and then they take an antidepressant that increases the amount of serotonin, and that corrects an imbalance and cures the depression. This paper argued pretty convincingly that that's not really what's going on. That's not how it works. Now, the people who are critical of that paper didn't really argue that the conclusion was wrong, that no, actually serotonin does cause depression. What they argued instead, and it's also my position, is that this paper proves something that we already knew, that the field of psychiatry has known for years, decades, I would say, that there is no chemical imbalance that explains depression that we know of. Another related thing that sounds scientific and maybe compelling to a lot of people is the idea that a class of antidepressants, the SSRIs, are selective. That's what SSRI stands for, selective serotonin reuptake inhibitors. The idea is that they only act on this one chemical, serotonin. The problem with this idea is that even selective antidepressants like SSRIs are non-selective. Once the serotonin changes in the brain, the other neurotransmitters change in response to that. In fact, a lot of things change because there's more serotonin. The cell receptors for serotonin downregulate, they become decreased in number, kind of as a compensation for the fact that there's more serotonin around. And we don't know, science doesn't know, medicine doesn't know, psychiatry doesn't know what changes in the brain that actually makes depressions decrease. And just to make the point in a different way, some of our most modern antidepressants are no longer SSRIs. They're not selective. They're intentionally non-selective. They affect the levels of serotonin and norepinephrine, or sometimes dopamine. And actually, there are other antidepressants that don't work on any of those. So antidepressants seem to help, but we don't know why. That sounds like that's terrible and that's not like real medicine, but the truth is, that's been true of a lot of medicines that have nothing to do with mental health. We used aspirin for decades and decades without having any clue how it worked. We have a good idea now, but that didn't stop us from advising people to take 2 aspirin and call me in the morning. Back when that phrase became popular, there was no understanding of how aspirin worked. And yet we used it because it worked. And let me let you in on a little clue, a little secret from a psychiatrist. If somebody comes to see me and they have depression, and I decide that an antidepressant might very well be helpful for them, and then they come back, let's say a month later, and they're feeling better, I don't know why, not really. Could be the chemical, it could be a biological change thanks to the antidepressant. It could be placebo effect. It could be that they feel better, that I was trying to take care of them and they were able to tell me their story, and the medication gave them hope. Could be psychological. Could have nothing to do with me or the medicine. Maybe something changed in their life. Maybe they heard something out in the world. Maybe one of their friends said something. But here's the secret. I don't care. There's so much discussion about how much of the benefit from antidepressants is chemical and how much of it is just placebo effect. You kind of lose sight of the fact that by and large, people feel better when they take an antidepressant. They do. There's really no controversy about that. The controversy is it all psychological? And we shouldn't be prescribing medications, and they shouldn't be sold by pharmaceutical companies. They don't really do anything biologically, right? But on an individual basis, when I'm seeing an individual patient, I really don't care. If they're feeling better, that's good. And that's one thing that's really different about psychiatry versus other areas of medicine. If we were talking about a cancer treatment or about a treatment for an antibiotic, for example, the fact that the patient subjectively felt better but their underlying disease wasn't getting any better and they were actually getting worse. The cancer was still eating away at them. And, but they said, oh no, doc, I feel better. That would be a real problem, right? That's why it's really important in the rest of medicine to be clear about whether there's a placebo effect or whether there's a chemical, biological effect of the medications. It doesn't matter as much in psychiatry. If a person feels better, if they're less depressed, less anxious, more comfortable, happier, that's good. And that's all I really care about, honestly. Now, there are some details there that we could get into. You could think about a little bit whether antidepressants are preventative, they'll stop the next depression from coming. But these are complicated issues because psychotherapy also can stop the next depression from coming. Changes in one's lifestyle can do that too. So there's nothing really specific about a chemical treatment, a pharmaceutical treatment for depression. It really differentiates it in that way. And so I say again, if the patient's feeling better, they're good and I'm good. Now let me get back to that thing I said at the beginning about when we do understand the cause of a psychiatric or emotional problem, it leaves psychiatry and goes to another field. This has been a historical truth over and over again. Many times, conditions that were originally thought to be mental conditions, psychiatric conditions, turned out to be biological ones. Dementia is a pretty good example of that. But, you know, brain tumors, glandular conditions, Huntington's chorea, which is a genetic disease. Lots of things look like mental conditions, but they're not. They're medical problems. Certain kinds of toxicities, metabolic abnormalities, and so on. There's really a long list that we psychiatrists have to know. Now, is it possible that the conditions that we currently think of as psychiatric have a chemical or biological explanation? Sure. It may turn out that schizophrenia, for example, will be explained at some point in the future through biological mechanisms, genetic or whatever it is. When it does, think about this, when it does, psychiatrists won't treat it anymore. If it's a genetic problem, it will go to geneticists. If it turns out to be an inflammatory problem, it will go to rheumatologists or whoever treats that kind of inflammation. If it's not a tumor, but if it was a tumor, it would go to oncologists. Tertiary syphilis, advanced syphilis, the sexually transmitted disease, in its late stages causes something that looks very much like a psychiatric condition. But of course, that's treated by infectious disease doctors, not psychiatrists. So as soon as something is understood in terms of the mechanism, it leaves psychiatry. We are left with the realm of the unknown. Now, for some people, that's a turnoff. That's why they become internists or surgeons or dermatologists or ear, nose, and throat doctors. They do something other than psychiatry. But those of us who like it think that's the most interesting part about it, that we don't really understand this, that it's a realm of mystery. So look, in closing, we in psychiatry, mental health professionals, don't have to lie and say we understand something when we really don't. It doesn't make the public respect us more. As a matter of fact, it makes people more skeptical about what they can believe about what we say. The truth is, we help people with statistical estimates. You know, on average, more people feel better on an antidepressant. It doesn't mean you will specifically, of course. That's just a statistical hunch, basically. We go with educated guesses. We go with clinical experience. We go with intuition, especially in, well, I was going to say especially in psychotherapy, but actually also in medication management. choosing which medication to use for depression or for other conditions sometimes is really a matter of taste or personal anecdotal experience more than anything else, because they're kind of indistinguishable scientifically. The field is young. It's bound to continue to improve. I certainly hope it will. But for now, let's not have premature closure. Let's not make ourselves sound too simplistic in talking about chemical imbalances and trying to explain what we do using simplistic cartoons about, you have not enough of this chemical, so we're going to replace it, like we're a filling station and you're low on gas. That's not really how it works. Anyway, that's it for today. Please like this video, but only if in fact you like it. Since I mentioned the playlist that I've been doing on myths about psychotherapy, please check that out. And please subscribe if you have not already. Thanks, and I'll see you next time.